Spinal cord syndromes in MRCS. Spinal cord containing descending tracts, lateral corticospinal and ventral corticospinal. These tracts are motor containing descending orders to the muscles of your body. So lateral corticospinal tract, this is the main one, containing 90% of nerve fibers. Ventral corticospinal tract, it is cortico from the cortex and going to the spinal cord. So it is descending motor tracts. The ascending sensory tracts, 3 portions. Dorsal column containing deep touch, vibration, proprioception. Lateral spinothalamic, spino to the thalamus, and ventral spinothalamic. So these are ascending sensory. Lateral for pain temperature from contralateral side, ventral light touch. Another question here, very important to know, thoracolumbar lesion. Lesions containing lateral horn cells. Lateral horn cells containing sympathetic nerve fibers. So very important question will be asked in the MRCS exam. Another question regarding the type of nerve fibers. We have A alpha, A beta, A delta fibers. All of these fibers are myelinated. The most important one is this A delta fiber for transmission of localized sharp fast pain. C fiber, unmyelinated fibers for transmission of dull aching, burning, diffuse pain, slow, because they are unmyelinated fibers. So don't forget, A delta and C fibers are nociceptors, transmitting pain. Okay. Different types of spinal cord syndrome. The most common one is central cord syndrome. Central cord syndrome. This will be due to affection, injury to the central region of the spinal cord. The affection central portion of corticospinal, this is descending motor, and decussating fibers of lateral spinothalamic, this is ascending sensory. So this is the most common type of incomplete cord syndrome and occurs in the elderly with pre-existing degenerative changes in the cervical spine, especially syringomyelia. This is degenerative spinal disease, okay, characterized by syrinx formation, okay. Other diseases like degenerative spinal disease, cervical spondylosis, traumatic disc herniation, and various hyperextension injuries like car crash leads to whiplash injury. What is the affection? We will have variable sensory and bilateral motor affection. Bilateral motor, upper more than lower extremity affection, distally more than proximally. Here, why upper extremity is more than affected? Because the leg fibers are more laterally, so the injury is central. The injury is central. So the affection of the legs are leg fibers located laterally because of this disproportionate lesion. But the arm fibers are more medial, so the affection to the arms more than the legs. We will have also variable sensory impairment, okay? Loss of pain temperature, contralateral pain temperature, especially in the arms, because this is central, taking the whole portion of the central portion of the spinal cord. So we'll have loss of pain temperature in the arms. The diagnostic CT versus MRI. CT for trauma, MRI if you suspect tumor. Central canal syndrome or central cord syndrome, it is of relatively good prognosis. Here, still in central canal syndrome or central cord syndrome, we will have like syringomelia, the affection of the central portion of the spinal cord. Syrinx means cystic lesion. Okay, we will have affection of this area. Okay, so you will like the affection of CCC4 portions. The upper limbs are more affected than the lower limbs because the affection of central portions in the damaged region zone. We will have bilateral damage to the anterior horn segments leads to motor, anterior horn cells motor, dorsal sensory. So anterior horn cells leads to flaccid paralysis and spastic paralysis due to damage of the medial portion of the left pyramidal tract, the corticospinal tract. So we can find spastic paralysis due to pyramidal tract affection, the descending motor tract. So upper limbs more affected than lower limbs in like jacket injury. And why upper limb is more affected? Because here the central portion is affected, arm fibers more medially, but leg fibers more laterally. Leg fibers are found more laterally. Anterior cord syndrome. Here, anterior cord syndrome, it is damage to the anterior 2/3 of the spinal cord. Okay, due to reduced blood flow or occlusion to the anterior spinal artery. It is called anterior spinal artery syndrome. It is 95% of cases. Due to atherosclerosis, vasculitis associated with diabetes or syphilis, also thrombosis or embolic occlusion, like aortic dissection, aortic aneurysm, trauma, iatrogenic during aortic surgery or spinal angiography or spinal aphasia. And here we will have another variant of anterior spinal artery syndrome we will mention later on. Severe hypotension due to hemorrhage and pathologic compression due to tumor or cervical spondylosis. Within hours, we will find the acute incident. Back pain and spinal shock. What is spinal shock? Bilateral loss of temperature and pain sensation. Bilateral loss of pain temperature sensation. And also bilateral motor function affection. Flaccid paralysis or quadriparesis. Also, we will have autonomic function affection, bladder, bowel, sexual dysfunction, orthostatic hypotension. Bladder, bowel, sexual dysfunction, orthostatic hypotension will be below the level of lesion. Okay. Also, we will find absent bulbocavernous reflex. What is bulbocavernous reflex? Squeezing the glans penis or pulling on a Foley's catheter while we are making digital palpation of the contraction of the anal sphincter. This is called bulbocavernous reflex will be absent. So it is supposed that when we squeeze a glans penis, we will find contraction of the anal sphincter. Okay, this will be absent. So this is the definition of spinal shock: bilateral loss of pain temperature, motor function, and autonomic function, plus absent bulbocavernous reflex. Late over days, we will have continuous sensory and autonomic dysfunction with a spastic paresis or quadriparesis, and the spasticity will be increased with also hyperreflexia. We have, this is called the anterior spinal artery syndrome. We have very important variant in MRCS. Apart from spinal artery lesion, we have lesion to the artery of Adam's quick. Adam Quick's artery feeds the anterior spinal artery. So if we make aortic aneurysm repair, okay, leads to reduce the blood flow or occlusion of the artery of Adam Quick's. So it is not a case of anterior artery compression or pathology or hemorrhage or hypotension. No, the artery that supplies the anterior spinal artery is called Adam Quick's artery. So this artery in aortic aneurysm repair will be affected. So it will be asked like this. The scenario, you will have patient with aortic aneurysm repair. Then features of anterior spinal artery syndrome. Like we said before, back pain or chest pain, then spinal shock, late spastic paralysis, and hyperreflexia. This is not anterior spinal artery syndrome. This is lesion of the artery, iatrogenic lesion of the artery of Adam Quick's. Don't forget, very important. As we said, spinal MRI for tumors, hematoma, or soft tissue lesions, bone lesions, and spinal cord parenchymatous abnormalities like infarction. If you suspect trauma, CT will be used. Okay, here is the blood supply of the spinal cord. This is a spinal cord, and this is the aorta. Here is the aorta giving posterior intercostal artery that gives spinal branch from the posterior intercostal artery. This spinal branch gives radicular posterior and radicular anterior arteries. This is known as the artery of Adam's Quick. This supplies the anterior spinal artery and thoracolumbar and sacral segments. So these segments are susceptible to anterior spinal artery syndrome. So in aortic aneurysm repair with no injury to, not isolated to anterior spinal artery, it is the problem of artery of Adam Quick's. So artery of Adam Quick's leads to lesion to the spinal artery because artery of Adam Quick's is the only feeding artery to anterior spinal artery in thoracolumbar and sacral regions. So we have anterior spinal artery syndrome, many etiologies. But artery of Adam Quick's, it is iatrogenic injury during aortic aneurysm or aortic repair. Okay. Okay, so anterior spinal artery syndrome, we will find affection of the following. Below this lesion, we will find sensory loss of pain and temperature from bilateral damage of the anterior anterolateral tracts, the ascending sensory tracts like spinothalamic tracts, anterior and lateral spinothalamic tracts, which carry pain temperature and ventral for light touch. We will find also dysfunction of the bladder and rectum from bilateral damage of lateral horn cells of the sympathetic nervous system. Spastic paraplegia, the green one, from bilateral damage to the pyramidal tract. What is the pyramidal tract? These tracts are descending corticospinal tracts, ventral and lateral. Okay, don't forget the previous diagram. Also, we will find at the level of the lesion, we will find bilateral damage to both anterior horn cells. So, anterior horn cells, we will find flaccid paraparesis. What is the difference between flaccid and spastic? Spastic with spasticity, okay, like lead by spasticity, and flaccidity due to hypotonia at the same level. This is anterior spinal artery syndrome. We will find acute incident or acute features and delayed features. Posterior cord syndrome. Okay, injury to the posterior portion or posterior 1/3 of the spinal cord, affecting the posterior column of vibration, pressure, proprioception, and fine touch. Vibration, pressure, proprioception. Only this portion will be affected due to occlusion of the posterior spinal artery or multiple sclerosis. Don't forget the tracts again. We have descending pyramidal tracts, motor, cortico from the cortex to the spine. So lateral corticospinal and ventral corticospinal. Don't forget the ascending tracts of dorsal column in dorsal or posterior cord syndrome. We will find only affection of deep touch, proprioception, vibration, and pressure. Deep touch, proprioception, vibration, and pressure. So only this portion in posterior spinal artery affection, which may be two arteries affection because the posterior spinal arteries are 2 in number. So we will find affection only to the dorsal column ascending sensory tracts. So affection of only vibration, proprioception, and deep touch or pressure. Hemi section of the spinal cord. Okay, if we have hemi section to the spinal cord, like this, how the spinal cord affected this syndrome is called Brown-Sequard syndrome. Brown-Sequard syndrome, it is hemi section of the spinal cord, especially the cervical region, due to bilateral compression through trauma, penetrating the trauma by like knife or crash injury. Maybe disc herniation, lateral one, spinal epidural hematoma, spinal epidural abscess, or tumor, multiple sclerosis, or complications of decompression sickness syndrome. We will have two variants: contralateral loss of pain temperature due to affection of lateral spinothalamic tract. So contralateral because these tracts make decussation. Okay, decussation means that it will be from one side to another side in the spinal cord. So this decussation makes the lesion at the lateral spinothalamic tracts is contralateral loss of pain temperature. Okay, we have ipsilateral motor lesion. segmental flaccid paralysis at the level of the lesion and spastic paralysis below the lesion with ipsilateral Babinski sign. So again, Brown-Sequard syndrome or hemisection of the spinal cord, you will find contralateral loss of pain temperature due to affection of the lateral spinothalamic tract. So contralateral pain temperature. Ipsilateral paralysis, ipsilateral Babinski sign, ipsilateral loss of vibration, proprioception, deep touch due to affection of dorsal colon. So, contralateral pain temperature due to affection of lateral spinothalamic because this decussate the dorsal colon, no decussation. So you will find loss of ipsilateral loss of proprioception, vibration, and tactile discrimination at below the level of the lesion. At the level, you will find segmental flaccid paralysis and spastic paralysis below the lesion. With ipsilateral, all of this ipsilateral Babinski sign. Only contralateral pain temperature. All of this are for Brown-Sequard syndrome. Why we have segmental flaccid paralysis at the level of the, because of this is lower motor neuron lesion. Lower motor neuron lesion, so is flaccid paralysis. Okay, because the upper motor neurons are okay above this lesion. So this is still make the inhibition, the inhibitory effect. So this is a flaccid paralysis. But below the lesion, this is upper motor neuron lesion. So it is a spastic paralysis because of the absence of the inhibitory moderation of the these fibers. So it will find spastic paralysis. Again, because all will ask about this, we have ipsilateral loss of dorsal colon sensation, proprioception, vibration, and tactile discrimination. Ipsilateral flaccid paralysis at the level of the lesion because of lower motor neuron lesion at this level. Okay, lower motor neuron lesion at this level. But below this level, you will have upper motor neuron lesion. So the effect of upper motor neuron lesion will be absent below the lesion. So you will find spastic hyperreflexia paralysis. Spastic paralysis with hyperreflexia because of the absence inhibitory effect of upper motor neuron lesion below the lesion. Don't forget contralateral pain temperature. So Brown-Sequard syndrome, very easy by this way. Here, the Brown-Sequard syndrome last time. You will have contralateral pain temperature due to affection of the contralateral spinothalamic tracts. Flaccid paralysis due to damage to the anterior horn cells at this level. So it is lower motor neuron lesion at this level. Spastic paralysis, damage of the pyramidal tracts. This is upper motor neuron lesion. With ipsilateral, so the lesion is this side. This side, you will have Contralateral. Then temperature due to the cassation of the spinothalamic tracts. The lateral spinothalamic tract. So contralateral loss of vein temperature. Lateral. Classic paralysis at the level. Ipsilateral. Spastic paralysis below the level with ipsilateral Babinski sign. This is Brown-Sequard syndrome. In summary, we have this table. Central cord syndrome, most common one due to hypertension injury, may be associated with chronic cervical spondylosis, pharyngomelia, and also spinal cord compression. You will have jacket deformity, upper extremities more affected than lower extremities. Anterior cord syndrome and its variant, Adam-Quigg's artery affection due to aortic repair. Here, another variant. The affection is motor and sensory. Bilateral, because this is anterior portion as a whole. So the affection will be bilateral, like pantalon, trousers, affection. Here is jacket affection, central cord syndrome. Here is pantalon or trousers affection, bilateral motor paralysis, loss of pain temperature, and autonomic dysfunction below the level of the lesion. With spinal shock, means motor, sensory, and autonomic affection below this lesion. Okay, so this will be like this. The lesion here is jacket. Here the affection will be like this, like trousers affection. In posterior cord syndrome, only affection of ipsilateral loss of dorsal column sensations, which are proprioception, vibration, and tactile discrimination below the level of the lesion. No motor affection because it is posterior cord syndrome, posterior one-third only, like trauma, occlusion of the posterior spinal artery, and multiple sclerosis. Last, Brown-Sequard syndrome, section of the spinal cord, trauma with knife, spinal cord decompression from the side. So the affection is one side of the cord. So all tracts will be affected. Ipsilateral and contralateral. Contralateral because the spinothalamic, so lateral spinothalamic carries pain temperature. So loss of contralateral pain temperature 1 or 2 levels below the lesion. Okay. And ipsilateral the following. Ipsilateral dorsal column affection. So loss of proprioception, vibration, and tactile discrimination below the level of the lesion. Ipsilateral mental flaccid at the level of the lesion because of lower motor neuron lesion at the level. Spastic paralysis below the level of the lesion because of upper motor neuron lesion or absence of the inhibitory effect of upper motor neurons leads to spasticity and hyperreflex. Also, ipsilateral Babinski sign. Thank you. We have finished. If the topic needs discussion, please tell us to make illustrations like this. If you like this, please subscribe our channel. Thank you.